All right, Mr. Chairperson, I believe we're good
We're good?
and prepared to start.
Okay. Well, welcome everyone to the February 22nd, 2024 EMS meeting. And the meeting's live streamed and recorded. And I'd like to acknowledge that we're on the traditional territory of the Anishinaabe people under the Robinson-Huron Treaty of 1850 and the waterways traveled by the Métis of this region. And we will begin by asking if there's any additions to the agenda. Chief Thompson?
Yes. So with the discussion with Councillor Sheard yesterday, I do have an addition for, I think it would be number 8.3. If Ms. Skinner can just nod her head and confirm that's what it would be. 8.3. And I have a motion here that can be reviewed at this time. I can just read it out now if you would like for it to be adopted into the agenda.
Sure. Yep.
Okay, so the motion to be considered at 8.3 would be that the EMS Advisory Committee requests staff to investigate opportunities of Aero Future Canada's autonomous drone technology and to report back to the next EMS Advisory Committee with the progress.
Okay. All right. Any other additions to the agenda? No. Okay. I see Joel Constable zooming in there now.
Yeah, sorry about the delay. Unfortunately, my camera quit working this past week, so I am here, but and I am awake. So
Okay. All right. That's good. So mover and seconder then for the agenda. Pearl and Scott, that the February 22nd, 2024 Parry Sound District EMS, or I should say District Emergency Medical Services Committee meeting agenda be approved as amended. All in favor? And that's carried. I see Ann's coming in here now, Dave, on screen. Is there any disclosure of pecuniary interest or the general nature thereof? No? Okay. And may I have a mover and seconder for the minutes? Shelley and Scott, the minutes of the October 26, 2023 meeting of the Parry Sound District Emergency Medical Services Committee meeting be approved as circulated. Was there any discussions or comments on those minutes? No? All in favor then? That's carried. Okay. Deputations. Dave, you've got someone to introduce to us?
Yes, thank you, Ms. Chairperson. I would like to introduce Tom Smith. Tom is our EMS supervisor for community paramedicine. I invited him tonight to provide an overview of the community paramedicine program that we're utilizing in the district. So this is our flagship program that is outside of emergency response. And Tom has been a community paramedic. He's now the supervisor. He's absolutely passionate about this subject. And I'm hoping that everyone will be able to gain a little bit of insight about the ways that we touch people's quality of lives throughout the district with this program. So if it's okay with you, Mr. Chairperson, we'll
Yep.
let Tom provide a 10 to 15-minute presentation. And then he can answer any questions of the members before he goes to be with his family for the rest of the evening.
Sounds good. Welcome, Tom.
Hello. Thank you. Thank you for having me and allowing me to just explain what we do. Community paramedicine it's new, but not too new. It's been around for almost a decade now in the province, and it's an industry it's growing exponentially with technology and innovation. And I actually, funny enough, just returned from a 2-day community paramedicine knowledge exchange down in Toronto, where there's 57 community paramedicine programs active across the province, and they all have grown in the last 5 years exponentially. And the innovation, the technology that's out there is just, like I say, absolutely incredible. But just to kind of give a quick, brief overview of what our program is. Currently, we have 6 paramedics that are dedicated strictly to community paramedicine. Community paramedicine means they are proactive. We're trying to prevent 911 admissions. We're trying to provide healthcare, fill in the gaps in community. We have 3 working full-time on the west side of the Parry Sound District, and we have 3 working full-time on the east side of the Parry Sound District. In addition to doing scheduled home visits, they're also response ready. So if they are available on the air and a 911 call comes in, they can first respond to the calls. Just to give you an idea of how many people we're actually seeing currently, we have 617 patients rostered on the program across the entire district. Of those 617 patients, 13 of them are considered palliative. 40 of those patients are homebound, meaning that they have no ability to leave their homes. They're completely bedbound, and without an ambulance transporting them, care needs to be delivered to them. On average, we also have remote patient monitoring. So in addition to our home visit program, we utilize remote patient monitoring, where we'll actually go into a person's home and we set them up with blood pressure cuffs, SpO2 monitors, blood glucose monitors, and weight scales, thermometers. The patient's instructed and taught how to take their own readings, and those readings are actually uploaded to a database that we have. So our community paramedics can actually monitor their vital signs remotely from our office. And the software that we use is actually trained to look for anomalies. So if a person's vital signs actually go outside of their preset parameters, it'll actually send us an alert. So we know that a person's blood pressure is escalating. And with the software, it allows us to predict certain poor outcomes. So an example is if we put it into someone who has CHF or heart failure, we know that if a person's weight starts to slowly escalate, their blood pressure increases and their SpO2 decreases, we know that they're having a COPD exacerbation. So it allows us to move in for early intervention before it actually turns into a 911 emergency. Same with COPD. We can actually predict COPD exacerbations before they happen, and it allows the paramedics to move in before the event actually occurs. And again, with our remote patient monitoring, we have an average of about 40 people on remote monitoring per month, and we utilize it for everything from patients being discharged from the hospital and they're starting on a new medication, or there's been an event where they're starting on a Lasix treatment, for example, for fluid retention. We can now move in with our monitoring equipment, monitor it for a few weeks, few months. We've monitored people for years in some cases. During the pandemic, we were utilizing this technology for people during the COVID outbreak, where if someone was high risk and they were tested positive for COVID, we would go in and put in the equipment while they were on antiviral medications to monitor them remotely. So they're at home, but we're making sure that their vital signs are still stable. Going back to our numbers again. So from the 2023 year, we performed 2,443 home visits. We also, in addition to that, we did 5,734 telephone wellness checks. We also run clinics. So in addition to going into people's homes, we actually will set up wellness clinics in congregate senior buildings and DSAB buildings for people that don't necessarily have equitable health care. At those clinics, we saw 1,158 patients. We also, during cold and flu season, we administered 640 vaccinations last year. We did 78 vaccinations in patients' homes for homebound patients and their caregivers. So these numbers are massive when you look at our population for the amount of patient contact that we're having. In the last 5 months, we've made some changes to our program. We now have 15 new medical directives that we have a medical director that is our medical oversight. So we actually carry 15 different medications that we're authorized to administer to patients in their home and at clinics. We do advanced assessment skills, from mini cognitive assessments to mobility assessments, again, in patients' homes. We use an EMR software, which runs off a tablet just like this. So all of our reporting is done at bedside. We do all of our charting and reporting in real time. And these tablets are actually outfitted with e-fax. So before we even leave the patient's home, we can actually fax our reports to primary care, to other allied agencies, home and community care, community support services, mental health and addiction, even to the GEM program at the hospital, diabetes education. We're able to do all of our referrals directly from our tablets. We do point of care testing in patients' homes. So people that are on warfarin, if they're homebound, we can come in and we can use a device just like this, and we can actually take blood samples and we can check their INR, the clotting factor in their bloods. And again, we work with anticoagulation clinics in hospitals, both North Bay, Parry Sound. We work with family health teams that also follow these patients. Our goal is to soon be doing in-home lab draws where we can be doing portable, it's called portable lab work. Basically, it's a machine slightly larger than this where you take a blood sample through phlebotomy directly out of the vein like you would if you went to a Life Labs, but you can run it through a machine. You can get a full blood workup within 15 minutes. It's quite incredible, the technology. We've also had all of our paramedics recently trained in wound care through the lower limb preservation program out of Health Sciences North. So now our paramedics are actually trained to assess and do wound care in the community. In addition to that, we now have ultrasound Dopplers. So part of our assessment now is we're doing early detection for peripheral arterial disease. So it's a very simple 15-minute test, but we can now check to see what the circulation is like in someone's legs. And if there's a problem, we can now refer them to a vascular clinic. So now, people with, diabetics, these wounds that just do not heal, we can do early intervention. We also have a phone system. So access for us was always an issue. So we're now running a phone system where we have a single phone number for access for all of our community partners and all of our patients. And it's pretty neat, the system. Patients can call and they can immediately contact any of our clinicians or coordinators within the program. If the clinician or coordinator isn't working that day, but they need immediate help, they can actually hit a button where it will automatically forward their call to everybody working within the community paramedicine program. So it's essentially a non-emergency line for EMS, and it's designed for those patients that are on program and they can't get a hold of their family doctor. They have a problem, whether a minor ailment or whatever it might be. They want to speak to somebody. We're talking seniors here. They try calling their doctor. They can't get through to them. Who else do they call? From our experience, they call 911. So this right now is a non-emergency line that they can call. They can speak to a paramedic right away. And so we've been tracking those with our statistics. They're called high intensity home visits now. So they speak to a paramedic. We dispatch one of our community paramedics that goes out to see what the situation is. They then assess the patient and they determine, is this an immediate issue that requires, well, first they screen it on the phone and they determine, is this an immediate 911 emergency, and they'll dispatch an ambulance. If it's something that they want to take a look at, the paramedic will go. They'll then take another assessment and determine, okay, should this be seen by a physician with immediately in emerge, or is this something that we can do a referral to, or we can treat another path through a different pathway. So this has been live for about 5 months now, and in the past 5 months we've taken 133 high intensity phone calls. Out of those 133, only 17 of those have actually been 911 escalations. So if you consider those rest of them, those were potential 911 emergency transport to an ED, like 911 escalations. So we're now tracking those as a 911 deferral. So every single 911 deferral, you can put a price tag on that of about $1,500 worth of savings towards the healthcare system, because that's what it costs every time a person walks into an emergency department. So the cost savings are absolutely incredible. We're using technology now for virtual care. So again, using our tablets, this system right here that I have, it's on a tripod, and it's a new program that we've started in the last 2 months, and we've seen absolutely incredible success with it. What we do is we will actually go into a person's home. Now, we've partnered with the Orphan Patient Clinic out of the nurse practitioner station in Point of Barrel. We have partnered with the diabetes education out of the hospital and the Parry Sound palliative program. And so what they do is, so an example would be the diabetes education. We have patients that are rostered with the diabetes education, but due to transportation issues, they haven't been going in to see some of them haven't been in to see the diabetes education in months. Now, these people, if they're not being checked on regularly, they're not changing their insulin, they're not getting proper nutrition, they're not taking care of their diabetes. These are all issues that will later on down the road lead to multiple emergencies. So what we do is we come in and we will actually set up this system, and we do a real FaceTime with the diabetes education. And basically the paramedic is the hands in the home with the specialist over our shoulder watching. The patient has a Bluetooth speaker microphone, so they can talk to each other, they can see each other. The diabetes education can make adjustments to medication. She can give advice. The paramedic in the home can give examples. They can reinforce the education. They can be showing how to do insulin injections. They can be checking the medications. They can be checking blood sugars, teaching the patient how to do all these things and reinforcing the education. It's been incredibly successful, and we've now got like 100% success ratio with people actually making it to their diabetes education. And we've had people that were completely uncontrolled, unstable diabetics that are now managing their diabetes in the home. When it comes to palliative, we have homebound palliative patients that need pain management, and we now are able to do the same thing where we're connecting with palliative physicians and home and community care coordinators at the same time to manage that person in home without taking them away. So we're making real-time changes to pain medication. We're making real-time changes to respiratory medication, nausea, vomiting. Our paramedics are all trained in palliative now. So, and we carry certain palliative medications on in our CP bags. We're also doing it with orphan patients. So patients that aren't attached to a family physician, we're able to go in and do the same thing, set up the camera and have them connected with a nurse practitioner. And we've had changes we've been treating cellulitis infections. We've been treating with antibiotics. We've been able to treat with antivirals for simple respiratory things. So it saves the person from going to emerge, from even having to go call 911 to go to the emergency department. So that's where we are right now. And just looking at what other services are doing, which align with what we're doing, we're seeing other services right now that have very similar demographics to us and situations where they're expanding their community paramedicine program to the point where they're now saving like 1,000 emergency department visits per month. They've been able to cut down on wait times in emergency departments from 6 to 8 hours to 30 minutes. Like they're seeing reductions in ED volumes, 15 to 20% in some areas. So that's what our goal is. Our goal is to continue with the technology and try and get ourselves to that point. That's pretty much the community paramedicine program in a nutshell. I know Dave told me I'm only allowed to speak for 15 minutes, but I could easily go on for about 2 hours. So I'll save you.
Tom, absolutely amazing. It has come so far. It's unbelievable. Joel, my camera's not working tonight either. Now it quit. So, but you can hear me okay?
Yeah.
Okay.
Absolutely.
All right, good. Anyway, thank you very much for the presentation. Anne has a question.
Yeah.
Well, first of all, congratulations, because I hear it in the community that this young man in a pretty uniform came to call on me and I don't have to go to the hospital anymore. So you are making a difference to the quality of life. Just a question, are all of your patients seniors, or do you do new mother visits, or are they all seniors?
They're not all seniors. So we have multiple funding streams. So we kind of break our patients down into, we receive funding through the CPLTC program. And those are designed for patients over 60, 65, generally geared towards people that are on long-term care wait lists. And we're basically trying to stabilize them in their home until they can they're either not quite yet on a program, but they're eligible. So that's one group. But then we also do a lot of, we work with the DSAB. So we do a lot of vulnerable people, and they're not necessarily senior citizens. We do a lot of mental health with people. I think the youngest person on our program that we've seen is in their 20s with unstable diabetes. So we're not trained so much in like maternity at this point, but we're focusing on a lot of mental health, addictions, a lot of the chronic conditions such as diabetes at this point. But I know there are some programs across the province that are all they're really expanding out. They're looking for they do a needs analysis to see, okay, where are the gaps? Where can we fill in? And if it's a gap, then it's something that we could definitely explore at some point.
Thank you, and congratulations again.
Yeah, thank you.
Any other? Oh, John?
Yeah, go ahead,
Good evening,
Tom.
Tom. Interesting presentation, great information. A much more fulsome program than I had than I was aware of. So awesome. I recently attended a meeting in our community I live in Brooks Falls, from Muskoka Algonquin, which was outlining their plan for their 10 years, 12 years out for their new 2-hospital program, their vision as to what that will be, and they're receiving some opposition on organization. But one of the things that they touched on was pushing services, Muskoka Algonquin, pushing services out into the community, and the role that community paramedicine was already playing with some of that. And I didn't ask the question, however, maybe this is a better forum anyway. So because Southeast Almaguin or Southeast Parry Sound District, let's say, is in Muskoka Algonquin's catchment area, do you have conversations with Muskoka Algonquin about connecting your services to clients with Muskoka Algonquin, or are you more centered on West Parry Sound and North Bay?
Nope. That's actually a great question. I'm actually meeting with them next week. So
Awesome.
yeah, I've met with the Brooks Falls Health team about 2 weeks ago, and we had that very discussion. And I was actually just with the Muskoka community paramedics over the last 2 days. And we had some great conversations over the last 2 days just about aligning services to make sure that we are offering the same services that they are in Muskoka. And Muskoka's got a very, very robust CP program. So it's we're working on aligning so we do offer the same services, and we will take patients. I mean, we're in such a unique area here in Parry Sound where we work with multiple OHTs, we work with multiple hospitals, we work with multiple home and community care. It's very unique where our patients come from. And actually, one of the conversations that we had with Muskoka was actually what we do with those patients right along the border of Parry Sound. So just a Novar area between south of Brooks Falls and Muskoka, and how we can work together where if it's something that they offer but we don't, we can actually do some cross-border work because it is with the same where the referrals are coming from. So the referral channels are opening, and we're hoping to open them up even further. And we are going to be working with our partners, the community paramedic program, even to the north with the Nipissing community paramedicine program. Same thing with some of those border areas like Callander. We have an agreement set up where if there's something that we offer and they don't, we can go slightly over and they can come down, just so we make sure it's everybody's getting the services that they need.
Awesome. Great, thanks. Actually, one more question, if I could. The high intensity, the program is high intensity. I didn't write it all down. Your phone system where they can reach out to get a hold of a patient can reach out to someone to get some advice.
Yeah.
Does that create logistical challenges for the rest of your program? Like if it's a case of I need help, I'm not sure what I need, I don't want to go, I don't necessarily need to go to the hospital, but in consultation with your staff, someone wants to go and visit. So a lot of what you do is very time structured with appointments, is it not?
It is. So we do have our scheduled appointments. Our high intensity, if it comes in, again, we triage it. So all of our patients, we have a 5-point triage system with all of our patients. If if they're in a triage level 4 and 5, that means they're able to manage they have supports in place. They don't necessarily need us coming on an ongoing regular basis. So what we do is we actually have a fridge magnet with our phone number on it, and we give it to them. And if they call us and they describe what the situation is, we have a checkbox. And if it sounds like it's an emergency thing, we'll say, this sounds like more of an emergency. We're going to send an ambulance out right now. And that crew can then go out and say, okay, if it is an emergency, they're going to take them to the hospital, or they can do a regular sign off, just like a normal crew would. We can usually tell them, we can make it out, usually with a high intensity, we can usually make it out within 1 to 4 hours. And we tell that patient, is that okay? Is 1 to 4 hours work for you? Pretty much most of the time, they're like, yeah, that's fine. And if there's any delays, we call them and we just keep in communication. And it's just that reassurance knowing that, okay, we're coming, someone will come, call us back if anything changes, if there's any changes. So, knock on wood, so far we haven't had any logistic problems with the system yet. And again, it's only open to the patients that we have on program. We don't open it up to the general population. And actually that kind of brings me to another point when it comes to our referral system. We've actually gone with an electronic referral system now. Pretty soon we're working on a website where we'll actually have all the criteria for the program, who can refer to the program, explain more about what the program is all about. We've actually written a 69-page standard operating booklet for our medics that outline absolutely all of our assessments that we do, all of the procedures that we perform. And that's going to be available on our website as well. So it's full transparency. People know exactly what we're doing. And I'll have our medical directives on it as well. And this link, when you go to our website, a referring agency will actually be able to put the patient's name into it, the address, and it will automatically it'll pop up the form, and it's a software program called CareDev that Home and Community Care is using. We're actually on their network and other community paramedic programs, and it will direct the referral, whether it's going to the east side of our district or the west side of our district automatically. Again, we get a lot of requests for people wanting to self-refer into our program. Unfortunately, we just don't have that capacity. So with the way the website will be set up, it'll actually explain, okay, who can refer? And it will really limit that criteria because knowing our capacity is a huge thing. And that's, again, why we use the triage system in the home. So I hope that answered your question.
Awesome. Perfect. Thank you very much.
Yeah.
Any other questions for Tom? No, I'm not seeing any. Tom, thank you very much for being here. Wonderful presentation, and thank you for all the work that you're doing. It's really, really appreciated. Please extend our thanks to the rest of the crew.
I will.
Well, yeah, and say big thank you to them for what they're doing, because it's not easy work. Yeah. A lot of times you're dealing with emotions, and it's yeah. So good for you. Anyway, you can go home to your family now.
I appreciate it. Thank you very much.
All right. Thank you.
Have a good night.
Night. Chief Thompson, do you have a report?
Thank you, Mr. Chairperson. So we can move right into item number 5, Director's Report in front of you. 2023 financial position. We had talked about a modest surplus. We're going to be able to achieve a modest surplus. It will take some time before the complete audit is available, but very comfortable with forecasting that modest surplus. I haven't worried about any of the 2024 financial position as of yet. Just we're too early in the year for me to be able to provide, significant information. You have a report on the agenda tonight with regards to Burk's Falls, so we can discuss that when we get to that point. I have put in here information with regards to EMS dispatch. Matt and I have had a few meetings recently with the Ministry of Health. They are going to be upgrading all the vehicle communications equipment around the fall of this year. That is then going to allow them to look into the upgrade of our dispatch center that's at the West Parry Health Center. Last meeting, we talked about the consolidation of all of the stations under one dispatch center. So once we have the vehicle equipment upgraded, they will then be able to move into that consolidation process with the dispatch centers. So that's going to be a fairly important move forward item to be able to consolidate our resources in that fashion. Henvey Inlet, I also previously talked about the possibility of a base in Henvey Inlet. That has moved somewhat with discussions with our field office. They are helped put myself in contact with Kenora District, who had recently gone through this process. The chief in Kenora was very helpful, and he's sharing their business cases that worked for them to be able to gain a bonded service in their First Nations. It's different than here. The distances are different, obviously, in the far north. And but we have, you know, volume differences with regards to travel and things that go on in our First Nations. So we'll work with that business plan, business case template, and Matt and I'll hopefully have something forward to the field office for their consideration. It'll take some time. This will be a multi-year project to be able to do that. Henvey Inlet is on board. They are planning a new fire hall there, which they're very comfortable in making it big enough to house a EMS base if we need to in the future. So we'd be looking at this being 100% funded by the First Nation as well as the province, and wouldn't be on the municipality's bill at all. I put a note in here about vehicle supply. This has been difficult since the pandemic started in terms of we used to get our vehicles within 3 or 4 months worth of ordering. We're now, you know, well over a year when vehicles come in. Some of our vehicles have much higher mileage than they used to when we turn them over. We haven't had any catastrophic failures or anything of that nature, but this doesn't seem to be resolving itself. So we are, you know, our vehicle supply is about a year out, and we do 2 or 3 vehicles each year when we're replacing them. So it's a little bit of a challenge, but it's a challenge for all services. This is the new normal. I would like to, this ties into what the community paramedicine ties into what Tom was just talking about. I was going to mention when he was finished, but I thought I'd wait till now. The community paramedicine program that Tom was just talking about, it's 100% funded by the province. So there are not municipal dollars that go into that program currently. The vast majority of the funding, $900,000 of it, comes from a program called Community Paramedicine for Long-Term Care. And it's supplied by the Ministry of Long-Term Care. That was a 3-year window that actually is expiring this March 31st at the end of the province's fiscal year. It's a challenge for us because in the fall, they had us do up budgets for an additional 2 years worth of funding, yet they have not provided us with funding letters as of yet. So it's only a month and a half away. All this is the same. Every municipal or every service is in this boat. All the ambulance services, and the ministry continues to tell us the funding letters are on their way, to the point that even last week they contacted me to make sure they had the CAO's email address to send the funding letters out to. We're expecting that this money has not been indexed as they give us the next 2 years. So the exact amount for that program was $904,800 was what we were receiving. That has stayed static for 3 years, and it looks like it'll be static for another 2 years. We do have some advantages that we've been able to refine our costs for the program. So we've been able to shift money to where we're spending it, and where it wasn't being fully utilized, we've been able to reduce those budget lines for the next 2 years. At a certain point, though, we won't be able to last on this funding without it becoming indexed. So as we move through the next 2 years of funding, and I'm confident we're going to receive those 2 years, as we move through that, though, we have to take a look at what's the program going to look like as it moves into the future. Traditionally, municipalities haven't been responsible for proactive healthcare. That's been the jurisdiction of the province. As you heard from Tom tonight, we now do proactive healthcare, and we are best positioned to do it because we're mobile and able to get out into the community. There are other groups that do things like that, of course. And Tom and his team have partnerships with many of those. What this is all going to look like as we move forward is we're not quite sure, but the healthcare world is evolving and these types of programs are becoming the norm, and we want to be able to provide these to our residents. So I'm sure that through the term of council that we're all in, we will be discussing this more about what it looks like in the future and where we draw the line in terms of municipal funding that would go into programs like this. So we'll have to have those discussions in the future. Right now, we're still looking at it being 100% funded. Matt also does a good job of finding smaller funding pockets for programs that gets added to this $900,000 to keep the program expanding and financially stable. Any questions on that? It's a big topic. The last item I have on my director's report is with regards to defibrillators. This is more a heads up for the committee as compared to anyone else. Our defibrillators are aging. I purchased them not long after I started here for the town, and we will be needing to replace them. Matt and I are working on a program to see if we can replace them over a 2 or 3 year period. As you can see from the report, the price tag for them is extensive. And this is one of those things that's the cost of doing business. The medics have to have the appropriate equipment in the ambulances and in the PRUs to do the work. And we will have to do these upgrades. We are going to look at, opportunities to keep these costs down. There are a few different programs we can look at. Some services are going with a lease program now where it's the same annual cost, and they just roll the defibrillators in and out as they need to. Another way we can keep the cost down is piggybacking on larger services when they order these. We're very small in the province when it comes to ambulance services. We have 90 employees. That's not the smallest service by any means, but it would be on the bottom half of the numbers in most services when we take a look at the number of employees. So there are services out there that get great discounts, volume discounts, and usually those larger services always have piggyback clauses in their tenders when they put them out. And we have had good luck in the past on working into those larger tenders to be able to get the best pricing possible. So we'll be exploring those avenues. This will be part of the 2025 budget, a program that will look at replacing the defibrillators. That's everything on the director's report.
Yeah. Thank you. Any questions for Chief Thompson? I've got a couple, Dave. This Henvey Inlet submission, is that going to mean utilizing the existing envelope of paramedics that we have? Or does that mean we're going to have another additional couple of paramedics?
So this would be an additional base for us. It's called a bonded service, and that's what the province wants to move forward with regards to servicing First Nations. So bonded means that it's tied to a existing service. It's not standalone. So the discussions with the Ministry of Health about other bonded services is that the Ministry of Health pays 100% of the costs. So it would mean additional resources and additional vehicle, at least one additional vehicle, and an additional base. The province pays for that. Sometimes there's a little bit of back and forth with regards to where the housing for the medics occurs. In speaking with Kenora, they still don't have a base in the First Nation where they've got their bonded service. However, that being said, Henvey Inlet First Nation is very clear that they're stepping up to bat with regards to housing, and they will look after that component of this if we can move this initiative forward.
Okay, and now, because it's a bonded service, then will they be able to work in other areas within the district, or will it be specifically for Henvey?
To you, Mr. Chairperson, I think there's two components to that question. Because it's a bonded service, which means it's part of Parry Sound District EMS service, it acts as a resource that flows just the same as all the rest of our resources flow. So if an ambulance is stationed in Henvey and there's a accident in Bigwood, it would be the closest resource and it would flow that way.
Okay.
If we didn't have, if there was an incident in Key River area, the resource would flow that way. So it would act just like any of the rest of our resources flowing in our district as well as out of our district, because in that particular area, we're very close to Manitoulin and Sudbury. Right now, Manitoulin and Sudbury does a lot of the responses into Henvey Inlet First Nation. So a resource like this would flow throughout the out the district just like any other resource does. And that's because it's bonded. If it wasn't a bonded service, then it would almost be isolated just to the First Nation. The ministry doesn't want to move in that direction any longer. They want the resources to be able to flow and interact with the rest of the provincial resources. The other component of what you're saying, though, and I'm not sure if this is what your meaning was, staffing for this would be employed by the West Parry Sound Health Center just the way as all the rest of our staffing is employed by the West Parry Sound Health Center. Matt and I have talked about the challenges of being able to staff a base that far away. I also spoke to Kenora about that, and they face similar challenges in terms of being able to staff a resource that way. There is an opportunity, and Kenora has taken advantage of this, of trying to find residents of their First Nation and move them through the training programs to be able to work in the First Nation in which they live. And Matt and I think that that would be an excellent avenue to pursue as well. So there's a number of opportunities that we'd have to pursue and challenges as well with regards to this. But what it does do is it puts a resource at the furthest limits of our district that can help to supplement our other areas.
No, the advantages are immense as well. I just wanted clarification on how that was going to work, and I'm sure it will get flushed out further as we go along. So appreciate that. Thank you. John.
Question for Dave. With aligning with your question, Mr. Chair. Dave, what you're working on for what you're working towards for Henvey, is that a 12-hour car, a hybrid, like an 8, 16, a 12, or a 24-hour car? Like what are you working towards?
Through you, Mr. Chairperson, in speaking to the field office about it, we think the most practical solution immediately would be a 7-day-a-week, 12-hour car. That could be expanded in the future, but that appears to be what would be the appropriate resource to put in that area now. We would also, if this resource came online, we would probably start figuring out how it could stagger with Point of Barrow as well as Argyle, so that we can get coverage beyond just 12 hours. We don't want all those 12-hour cars lining up perfectly. We would match them to the call demand so that we're getting our best bang for the buck in the different areas.
So you wouldn't necessarily be advocating there to making that a callback station. You would keep it as day only, or the 12-hour window only.
For you, Mr. Chairperson, with regards to it's very difficult to put new callback in place anymore. We have callback in a couple of situations, but with regards to contract issues, it's very hard to implement that for everyone, all services in the province anymore, to initiate new callback. So it would be a 12-hour service, and there would be no service outside of those 12 hours from that particular base.
Awesome. Thank you.
Any other questions on the report? Nope. Okay. Can I have a mover and seconder then for the report? Anne and John, that the Emergency Services Director's report dated February 22, 2024 be accepted as submitted. All in favor? That's carried. Statistics.
Through you, Mr. Chairperson, I'm not going to dwell on the statistics. They're here for everyone's interest and information. A very typical year. The chart at the end shows that our numbers were actually down slightly from the year previously, which is nice because you can see the growth that was occurring. So that helps us a little bit from a unit hour utilization standpoint. Other than that, the numbers show we met all our response time standards this year, which is a very good thing. It's especially for the sudden cardiac arrests, it can sometimes be difficult to meet those numbers, but we were able to meet them this year. With the distances that we have in the district, it sometimes becomes very difficult. We're able to meet those response time standards. So that's 2023 statistics there.
Good. When did so we've got the transfer vehicle that's working now. When did that come into play? Like,
For you, Mr. Chairperson, that came into play about half of the way through 2023. So where you can see, well, actually, I guess it was about half the way through 2022, maybe. So how you
Okay.
can see that is on page 1 of the statistics. If you take a look at the long distance transfers, the 2023 year to date, which is the full year, is lower than what it was in 2022. That's a direct result of the patient transfer vehicles that are now being funded by the hospital, totally separate from EMS. And that's a direct correlation to the impact that it's having. Those numbers used to be up with regards to, in 2021, it was almost 1 long distance transfer a day. And so they started coming down in 2022, but you see a full year of the reduction in 2023.
that's good.
It is good. And additionally to that, although it's not in here anywhere, the hospital has now received stable funding for those transfer cars. Well, I'm going to say transfer cars because they're utilizing the funding to hire multiple different transfer services. So I believe they received a 4-year window of funding to do that. So at least for the next 4 years, they're going to have funding to ensure that for the most part, EMS is not utilized for those types of transfers that they don't need to be utilized for.
Right. Good. Good. John.
The report that is EMS, District EMS monthly night calls 2023. Could I ask a question specific to code 8s?
I'm trying to find the night calls.
It's actually next to
Yes,
the
it's the
call log.
last one. Okay.
So something jumped out at me, which I find kind of curious. There is, for all of the stations, the latter part of every night shift in every station, in every month, from 4 to 7, 4 to 9, depending on the shift pattern, has 0 callback, or sorry, 0 code 8s in every month. So is that accurate that there are no code 8 calls for any of the stations in the last 3 or 4 hours of every nighttime shift?
Through you, Mr. Chairperson, I will follow up on that to just confirm it absolutely for sure. You can see that the numbers for some of the stations are low even outside of that. And I would suggest that I suspect they don't move those cars on code 8s in those particular hours. I will follow up to make sure that that's not a misprint though, and confirm for the committee.
Thank you.
Any further questions? No? Okay, mover and seconder, please. Shelley and Pearl, that the EMS committee members have received reports 6-1, 6-2, 6-3 as listed above. All in favor? That's carried. Thank you. We have no ratifications from closed. We've got other business 8.1. EMS Advisory Committee recommends that the Town of Parry Sound Council approve the report DT EMS surplus ambulance disposal. Can I have a mover and seconder for that? Scott and Ann, and discussion, Chief Thompson?
Through you, Mr. Chairperson, with regards to this issue, I guess a little bit of historical context would help. Years ago, I mean, not that long ago, there was high demand for the ambulances as surplus vehicles to go to the municipalities to act as first response vehicles. That demand has fallen off almost completely at this point. And for the past 5 years, probably at least, there's been very few requests for surplus ambulances. Also, within the past 5 years, the cost of the ambulances has gone up significantly in how much we're paying to get them. So there are really primarily 3 municipalities or 3 organizations that continue to request the ambulances, and they are municipalities that run extremely robust tiered response programs, and it's Kearney, Whitestone, and Henby Inlet. Due to the significant increase in the cost of ambulances, as well as in our disposal in the past year, we are getting significantly more for our ambulances. I wanted to have a discussion with the committee about how we need to move forward. Now, I'm not particularly partial to any solution in this issue. I think that this is much more of a political decision than an operational decision. I'm trying to put the facts on the table for the committee members, and I've come up with a recommendation for you to consider that's straight down the middle. But there are 2 extremes to the issue. Previously was one extreme. We always gave these ambulances to municipalities who requested them. The other extreme is to sell them for the most money we can get, which is what I've done for the past 2 or 3 years, because there hasn't been many requests. Right now, one of those 3 municipalities or 3 organizations that still like to partake in it and do run a robust tiered response program, Whitestone, is requesting an ambulance. And so I told them that this report was coming forward and then I would get back to them once the committee had made a decision with regards to this particular issue. So I've proposed a middle of the road solution, which would be that partner municipalities would be able to receive surplus equipment at 50% of what the open market provided us the year before. That's simply a middle of the road solution. The other alternatives are to provide them free of charge to the municipality and forego the revenue that brings in, or to sell them for the most money we can. And in that case, what happens is when those revenues come in, they are rolled into the dedicated EMS reserves for capital purchases down the road.
John?
Dave, you've suggested that 3 municipal departments have robust first response programs. So when I used to work dispatch, those 3 communities plus at least one more had a provincially designated first response vehicle. So Ministry of Health would provide an ambulance radio, an EMS radio to that vehicle. So it actually became an ambulance resource of sorts, not just a municipal fire resource. So is that still the case? Do any of the the municipal departments in Parry Sound District still have a provincially designated first response truck with Ministry of Health communication resources.
Through you, Mr. Chairperson, two of those three organizations that I spoke of that have the robust programs do still have ministry call sign numbers and ministry radios, and that's Kearney and Henby. Generally now, though, those resources at one time were often absconded by the province. I wouldn't say often, they could be. The province could drag them around and utilize them in fashion to supplement other resources. That doesn't happen anymore. So the ministry will still supply radio and will still provide them with a call sign, but those resources never get dragged out of their municipalities anymore. So they act as a independent or a municipal resource solely for those municipalities that have them. And to the point where Whitestone decided that it wasn't necessary for them to maintain the ministry radio or the call sign that the ministry would have provided previously.
So does that, would you suggest, I'm not suggesting it does, but would you consider that those municipalities, those communities that have those vehicles would perhaps be entitled, let's say, poor word, but might have the availability to a resource from Parry Sound EMS at a more attractive cost than a fire department who doesn't have an affiliation necessarily quite so robust with supporting EMS?
Through you, Mr. Chairperson, so I don't believe, in my opinion, is not that simply by having a ministry radio and a ministry call sign anymore makes the program robust. Now what makes the program robust is the higher level of dedication that those particular municipalities provide to this tiered response program. And I'll give you an example. Whitestone, being in the middle of the 124 corridor, is at far reaches away from the ambulances. There's no base with an easy striking distance. They actually run significantly lower acuity, so less serious responses to provide a level of service to their residents and to assist EMS than what the town provides. The fire department here does do tiered response. However, it is virtually only for the most serious calls, VSAs, or if there's a delay in the ambulance. And that's simply because in the municipalities that are close to the bases, the ambulances, because they're staffed, will often get there before the volunteer firefighters can. That's not the case as you get further away from the bases. And all three of those locations, Whitestone, Kearney, and Henby, are a distance away from bases, and hence they run these robust or more robust programs than other municipalities run. So to further that a little bit, does that make them more deserving of an ambulance at lower cost to supplement their tiered response program? I think that's the political decision that I was talking to you about beforehand. All the municipalities run tiered response programs of some sort. They are generally geared towards what their municipality needs. The needs in a community that has a base are different than the needs of a community that doesn't have a base.
What am I driving at? Okay, thanks.
So if you wanted to amend this, add to it, you'd have to figure out what value you want to put on that ambulance for that that type of service. Retired ambulance.
Through you, Mr. Chairman, I think, you know, I have provided you with really a primary consideration, which is the recommendation, and two alternatives.
Yeah.
That other than those three options, I think it would get splitting hairs to try to
Yeah.
refine it much more than that.
Okay.
So, sort of up to the committee in terms of which of those they want to pursue. I'm happy to move any of those three options forward to town council for confirmation. I think we should limit it to the three options.
Okay. So who would like to put forward what option? Anne?
I just have a question.
Oh,
Oh,
Pearl?
sorry.
Okay.
For example, for Whitestone, if they were to receive one of these units, does that help us in the long run as far as not having to send ambulances out from the outreaching areas to go into there?
Through you, Mr. Chairperson, that's a great question. And it doesn't actually stop us from needing to go. The ambulances, the Parry Sound District EMS ambulances still need to go. What it does is it provides quicker care for the residents that are serviced by those municipalities.
Which is what we are looking for in the long run. Really, yeah. Okay, thank you.
Anne?
In terms of setting a value, you've referred to the govdeals.com. There must be ambulances like ours on the open market, used ambulances like ours on the open market that can set a pretty standard price. Is that true?
Through you, Mr. Chairperson, I mentioned the govdeals.com because I wanted the committee to understand how right now currently we dispose of them. And we have found that is what generates the highest amount of dollars. We've tried tendering them off before, and it hasn't been as effective as what we have now achieved with govdeals.com. So there will still be a need to dispose of surplus ambulances. Those municipalities requesting them is virtually down to the 3 municipalities, and they would never need all our surplus ambulances. So we will still be disposing annually of at least 1, maybe 2, and sometimes 3 ambulances. And the town of Parry Sound's procurement policy has us disposing now on govdeals.com, and we're getting almost 3 times as much as what we used to get through simple tendering or trade-in of these vehicles.
So I guess the other piece of my question is, if we put forward this council report and recommendation as you've got it at the 50%, there's no risk that 10 other communities will say, wow, what a great deal. I'd like those ones. If they see it on GovDeals? Or they
Through you,
wouldn't.
Mr. Chairperson, if it goes through GovDeals, then it'll be going for market value, whoever bids the highest.
Okay, so for these 3, you're just using GovDeals to get you a number in the back of your pocket. You're not putting it out publicly.
Correct. Through you, Mr. Chairperson. Correct. Other than that, it is in a public report. But what that is when we dispose of them through GovDeals, that is also a public process. So
Right.
everyone knows what we have received. Like all the bidders know exactly what the dollar figure was that the ambulances went for. So my 50% of the previous year was simply to send a benchmark of the market for ambulances.
Thank you.
John?
You know, there are some considerations, and we've discussed them, and perhaps they're not as easily managed and as worthwhile a consideration. So given that, you know, I think the plan that has been proposed previous years, GovDeals, and offering any municipal requests at half of that value is probably a great compromise plan. And in the end, I mean, we have to be fiscally responsible as well. Vehicles not getting any cheaper, and EMS not getting any more efficient, not efficient, more cheap. No, not getting any cheaper to run. You know, there is still a demand for us to manage surplus assets wisely. So you're right. I agree with Dave. This is a good compromise program that seems to make sense both for helping municipalities with first response and to grab as much residual value out of disposed assets. If you need a mover to propose this to Parry Sound for approval, I would make that motion.
Seconder? Anne? Okay, any further discussion on this? All in favor then? That's carried, thank you. Burks Falls base.
Thank you, Mr. Chairperson. I just need a sip of water. So, through you, Mr. Chairperson, I had previously talked to the committee about the offer of the tri-municipalities in the Burks Falls area that run their fire department of sharing a base. Preliminary costs came in fairly high and fairly broad for what it would be to share a base. Excuse me. And we decided that it was prudent to take a look at alternatives. Matt and I discussed the needs of the Burks Falls base. It is in substandard condition. It doesn't have the space, nor is of the quality of what we would expect in a 24/7 base. We have had this issue with other bases, most recently Point of Barrel, as well as the Seguin base, which we've upgraded to make them suitable for those bases were both 12-hour bases, but to make them suitable. Burks Falls is the next target that needs to be dealt with to make it suitable, and it is a 24-hour base in Burks Falls. I had some preliminary conversations with John as the representative from that area about what we were proposing to do, and we moved forward with getting a assessment of the current Burks Falls base and what it would cost to rehabilitate it and turn it into improve it so that it would be suitable for the next 15 to 30 years as a base moving forward. We don't see that it would ever have to house more than a single crew 24/7 in anywhere near the near future. And so we engaged Duncan Ross Architects to take a look at that project. They came back with some preliminary costs of rehabilitating the current base around $350,000. There are some additional costs that would be needed for tendering documents, contract administration, and such. However, that cost is significantly lower than the 1.2 to 2.4 million that it would be required to participate in the new build. From a fiscal management standpoint, obviously the $400,000 is much more likable. From an operational standpoint, I relied on Matt's discussion. He also spoke to the medics that actually currently work out of Burks Falls. They don't believe that there are significant operational enhancements that are achieved by moving into where the fire department is going to be housed in the new base, and that with upgrades to their current base, they didn't see why it wouldn't be suitable for the foreseeable future. So I'm bringing this to committee. The previous committee had directed us to investigate the shared space with the fire department. This is a deviation from that, moving away from that. The most common reason is for the cost perspective, and that there aren't significant improvements operationally to be gained by the alternative. This initiative would be similar to what we've done in both Point of Barrel and Seguin. And in those locations, we partnered with the municipality so that it was the municipality's building and ownership that existed where the base was. We can cash flow the project, and after the project is finished, we can then, through the municipality, have the municipality take out a loan through the government loan program where we would pay the costs off over a 15-year period to spread out the costs. The benefits to that is that we achieve 50% funding from the province rather than amortized funding. So it would be in the operational budget. We're doing this currently with both Seguin and Point of Barrel. The Seguin amortization is a 5-year period. It was the cost to do it were significantly lower than Point of Barrel. In Point of Barrel, it's spread out over 15 years. We'd be looking at this case in probably the 10 to 15-year period for the costs. What I'm asking for is direction to engage with Burkes Falls, the village of Burkes Falls, to determine if we can come up with an MOU that would allow for this to happen in 2025. If we're able to come up with some sort of an MOU, that would be coming back to committee for ratification. I'm not asking to move for a blanket a move forward position. We'd be bringing it back and letting committee take a look at it and determine if it was the course of action they wanted to pursue. So happy to answer any questions and explain more fully if there's specific questions about how we've done this previously with Point of Barrel and Seguin.
Any questions? Not seeing any. Mover and seconder. Scott. Ann. EMS Advisory Committee recommends the town of Parry Sound Council approve the report DT Burkes Falls EMS base rehabilitation. All in favor then? And that's carried. 8.3 drones.
Through you, Mr. Chairperson, I'd like to defer to Councillor Schurd to talk about this. He came to me with this initiative and had some ideas, and I think I've done enough talking for a little bit.
Okay, well, let me take over, have a drink on the house. It's great to see you all. I just wanted to alert you that it's come to our understanding, I believe, a company called the Aero Future Canada that has an autonomous drone that looks somewhat like a helicopter has approached most of the mayors in Parry Sound District about demonstration in Canada. And what I'm going to discuss with you, I'm not endorsing, only to say that we think it'd be, in our discussion at council, we thought about the applications of this, which could conceivably be for EMS purposes, that it could address remote and offshore medical emergencies. Potentially, it's got a quite an impressive payload and transportation of emergency and fire equipment to the same difficult or remote or inaccessible areas. And then public works, depending on the topology of a particular municipality, but you could imagine that transportation of equipment to the same kind of areas might be of interest. So so we thought that this would be best if we could refer to EMS that crosses all the borders within the Parry Sound District, instead of this company trolling every municipality for a demonstration, that we'd perhaps and ask AEMS staff to look into this from the purpose of how it could deal with emergencies, and then come back and see if there's of interest to set up a demonstration of its capabilities. So I was going to say, we haven't done much work on it. I know some of you are aware of it. In talking to Dave, thought it'd be best to bring this forward to the committee and look for support to a little bit of research into it and see if it may have some value in the toolkit for EMS and fire and public works. So that's in a nutshell, David. So I believe there's a resolution to propose that we ask staff to do that.
Yeah, there is. Discussion. Pearl, go ahead.
So what you're proposing is that there would be a drone that would be accompanying the ambulances when they go out? Is that what you're looking for?
No, it's really most of the mayors have been approached in our reeve with a potential demonstration of this rather large drone that has a 400-pound payload capability that could be involved in rescue and in a number of ways. And we never wanting to work outside of the emergency 911 system and fire and so forth. We thought it best to bring it to this committee because it crossed all the district of Parry Sound. So I haven't really thought beyond what I just told you. It's really just a pitch. It's a kind of a trolling across all our municipalities that have some interest, but we felt, particularly in our municipality where there's some very remote areas, this might have some application. And then thinking through how it might help our neighboring municipalities as well, similar topology. We thought we'd bring it here rather than every municipality sort of either responding or not responding to their sales initiative. So they've been at us twice now.
Okay.
So, Pearl, that's sort of that in a nutshell.
Okay, no, I was just as curious because our fire chief was also talking about that the other night at council meeting too. They were looking into it as well.
This is not the drone our teenagers are using. This is quite a large vehicle. So.
Okay, thank you.
John.
The name of the company again, could you help me with that? And
It's
today and afterward.
Yeah, it's Aero Future Canada. It's a Chinese company, technology, but has a distributor in Canada and the US now.
Okay.
Who's approaching municipalities.
Thank you. I guess obvious question might be to Dave. Is there, in order to devote staff time into exploration of viability, curious to know if we're looking for a resolution to approve staff time to do investigation. From Dave's perspective, does this offer any opportunities that are worth exploring, or is it a great idea but not necessarily the best fit for your service?
Through you, Mr. Chairperson, that's a really great question. I guess my response to it is that without exploring it, we don't know the extent of the applications that it could provide. And I do believe the extent of the applications is far beyond EMS. And maybe in the end, there are just too many regulations and too many rules when it comes to EMS. But there might be very effective applications that we're not even thinking about yet. So I think that I am prepared to put in the time to do some preliminary investigation and have preliminary conversations with this organization to see if it's worthwhile to pursue further with regards to, even having a demonstration or an information session where they could provide further information. I think anything like that would probably also include other emergency services like fire and police, as well as Councillor mentioned, the applications from a public works standpoint. Most of you know my life revolves completely around emergencies, and I can think of train derailments that I've been to where there could be just incredible applications, or floods, or things of those natures that we deal with maybe not very often, but once in a while. And I wouldn't suggest that it would be a waste of staff's time to at least do some preliminary investigations. We don't know what we don't know. That would be my answer.
Can I speak to this a little bit?
Joel?
Yeah.
Yeah, sure. Yeah.
So at McDougall Fire, we already operate a drone program. Nothing that would constitute carrying a 400-pound payload. But we currently do have a small drone that we use for rescue. We use it for many different things. It's a valuable asset. We're looking to upgrade our program. But once again, not to carry anything. The price tag, like we're talking not huge dollars, but $15,000 is probably what the next one's going to cost us. I can't imagine actually what something that's going to carry that kind of weight's going to would be. But I think you also start delving into a lot of other bigger questions. So we have to send away people to get their drone pilot's license. So there's a cost to that. We've had to create a program where we are making sure that our drone operators are getting sufficient time in to be able to continue to operate it. So there is quite an expense to it. I would agree that it's always worth looking into something because you don't know. My bias would be, though, that this would be something that would be quite expensive and not necessarily something that the EMS I could see using, when I could see fire departments in the future carrying a smaller device that would do 90% of what you're going to do. And once again, once you start moving payloads and stuff, I don't know. I've been on the fire department for a very long time and done search and rescues and that, and the amount of times you might have been able to use it, I think, are pretty negligible for the price tag and the bother for it. That's all I have to say.
Any other questions, comments? Anne?
Well, I just think Dave's hit the nail on the head that there could be all kinds of applications. I can see it for public works. I can see it for fire. I can see it for communications in an emergency situation. So I don't want to throw it all back to Dave, but maybe there's a way to create a little committee of 1 or 2 people from all of the disciplines to get a demonstration. It has landed at the Parry Sound Airport once. And I don't know who it was landing for, whether it was for a demonstration or whatever, but I do know that Neil at the airport said, holy smokes, this is a big drone compared to what he'd seen before. So, maybe it's not all EMS, but fire, public works, communications, take a look at it. But I think it's worth looking at. As David said, we don't know until we take a peek.
Kind of what Dave said. We don't know what we don't know. So, yeah. So I take it this is moved by Scott.
Right.
Seconder. Seconder. And any further discussion on this? No, all in favor then? That's carried. Well, see what this drone does. Yeah.
Excellent.
That I think is pretty much it, unless somebody else has something they need to add. No? Moving seconder to adjourn. Shelley and Pearl. All in favor? That's carried. Dave, I want to thank you and Sherry for your work on the agenda and everything tonight. Thank you. And to the rest of the committee, thank you for being here tonight. And Pearl?
Just to let you know, I won't be available for the May meeting.
Okay.
Do you want another representative or no?
What do you think, Dave?
Through you, Mr. Chairperson, our terms of reference doesn't allow for well, there's a name for that.
I know we discussed it at
alternative?
the beginning. I remember that. Yeah.
An alternate?
An alternate. So, we will send you all the information, and if there's someone who you think you want to, watch on YouTube so they can report back onto your municipalities, by all means.
Okay, perfect. Thank you.
Okay.
And
All
Dave,
right.
thanks for the offer of letting me come to the fire hall, but I was able to get home to my own house. So thank you very much for that offer. I may take you up on it another day.
Well, it's when you get stacked in meetings, right?
Yeah, exactly. And I didn't want to do the whole thing from the car.
No.